Week 3 of the class. Today we are moving into a little bit more of the structure and the function of the heart so we can get moving into the electrocardiogram. Some of the stuff we're going to go over in this class, this lecture that's going to go over the heart function and structure, is understanding disease. As we get into the EKGs, it's going to be important that we understand kind of the function of how the structure and the function is inherently different with disease and why eventually that's going to change the electrophysiology that's happening. So we're going to look at some congenital things that you may not be as familiar with. I do have students who are really intrigued by pediatrics and wanting to understand about, working with peds, and, I know Cincinnati Children's Hospital, UH, Chicago, some of the big cities have some really incredible cardiac rehab or clinical exercise physiology positions in pediatrics. And then understanding the difference between structural abnormalities, rheumatic fever, endocarditis, standard heart disease, and infarction and failure are some of the things we're going to go over. So to kind of start with some of the congenital stuff, when we think about congenital problems, atrial septal defect is one that you may be familiar with. It's about 7% of all congenital heart defects. Female to male is about 2-to-1 ratio. If left untreated, an atrial septal defect, left to right shunt can lead to enlargement. So oftentimes this would be a child who has a heart murmur at birth. They notice that there's a little murmur in there, and as years go by, you can end up seeing structural problems that lead to heart failure. So it's really important, especially if they're symptomatic, that it not go unnoticed. So when you're thinking about an atrial septal defect, it is just that blood flow. So here we're looking at the flow of blood on this first side. That's a normal heart. And then over here, this is a heart with the atrial septal defect. So what you see here is it's not nice and closed off like it's supposed to. So instead of the blood going from the atrium to the ventricle out to the pulmonary system for blood flow that's healthy, over here we end up with this septal defect that can really cause some symptoms and really be problematic. So it could require surgical closure. So that is, a surgeon's going to go in there and put a sheath in there, so close the method, so the artery that's going into the heart, the blood flow is not going the wrong direction, which again over time is going to change the structural component and really oftentimes have problems with valves. Another septal defect is a ventral. So when you look at the ventricular septal defect, this is during systole, so during contraction, blood is leaking from the left to the right ventricle, and it's going to end up changing pressure. So you have an increase in right ventricular pressure and pulmonary hypertension. Again, it can cause a lot of symptoms. Common symptoms are going to be cyanosis and not adequate blood flow. So what this is going to look like. So here's our, again, regular blood flow, right? So, oxygenated blood going out into the system. Then over here, right, so we end up with this mixture of blood that we shouldn't have because of this closure down here, right? So the difference between the atrial septal defect and the ventricular septal defect. So just where they're located, and then what would that mean, and what type of intervention is going to happen to the ventral. Most will heal on their own in the first year of life. Infants usually tend to initially be treated with medicines, and then depending on if the hole gets bigger or smaller, which kind of sounds funny, but with septal defects in infants, when a child is born with a hole in the heart, it can either get bigger and cause problems, or as the heart grows with life, it can on its own innately begin to somewhat kind of heal itself and close up. Another interesting thing is called transposition of the great vessels. So this happens I don't really know the exact cause, but these are potential risk factors. So a mother that has existing diabetes, a mother over the age of 40, a mother with alcoholism, poor nutrition, rubella or other viral problems. So transposition of the great vessels, kind of an odd thing that happens, right? So this is where the blood flow is going to change because of the way in which the blood flow is moving. It's hard for me not to have my finger on the slide for you to see, but again, healthy, we've got these chambers that are nice and closed, but over here, what you notice, right, this whole thing in the middle is what becomes problematic, right? Because the blood is not going in the right direction. It's not kind of sectioned off, which is what we call transposition between the aorta and the pulmonary trunk. So intervention for this is oftentimes going to be a surgery, and a surgery kind of confusing. Again, we're not doing surgery, but just know that this exists. A surgery that happens that's going to help try to keep everything so the blood's not mixing as much. So that's what we call transmission of the great vessels. Really not a difficult diagnosis, and I'm not really sure what else to say, but definitely surgical intervention. Another one is called tetralogy of Fallot, which is the physician's researcher's name. But tetralogy is formation now with the advent of really good ultrasound, pregnancy ultrasounds. A lot of times some of these structural functions are picked up on during pregnancy, but it's malformation that could potentially, again, rewrite the blood flow. And we can see it with pulmonary stenosis, overriding aorta, ventricular septal defect that we just spoke about, or right ventricular hypertrophy. So tetralogy is blood flow that is going to have an obstruction. Okay, so obstruction between. So what you're looking at, again, this is the same photo in all the slides, right? This first one is the same. The difference over here is this obstruction that happens, these chambers that forms kind of like a stenosis where the blood is not going where it should. Just by quick glance, without even knowing what you're looking at, you see that we don't have this nice, septal wall. We've got some obstruction that's in there. So tetralogy is another one that medication to help with the hypoxemia, right? Not enough blood flow. So oxygen beta blockers and surgery. Another kind of somewhat similar surgery where the surgeon goes in to try to help anastomose, connect, and structure those subclavian artery and the pulmonary artery to help better blood flow. So those are some of our really common ones. Another important one we're going to talk about is pulmonary valve stenosis. Valves do a job of closing and opening for just enough blood to go through. When we have pulmonary stenosis, the leaflets that are holding the valve become either defective or they become too thick, so they're not operating like they should. So when you have a valve problem, blood flow becomes restricted, pressure starts going up. So for this situation, it's higher pulmonary pressure, and then right ventricular hypertrophy. As that pressure, as the ventricle is working harder, it's getting thicker, hypertrophy, and that is going to push back and to cause pulmonary hypertension. You can see jugular distension, and again, cyanosis for not getting adequate blood flow. So here's an example of pulmonary valve stenosis. This is our pulmonary, and here we've got this thickened valve that's not allowing the right amount of blood flow to go through. What do we do for pulmonary valve stenosis? An intervention. Replace the valve, do corrective surgery, or there's ways that they can go in there with a balloon and do some kind of balloon plasty. Okay, another one you may or may not have heard of is patent ductus auratus, which is an irregular blood flow from the pulmonary artery into the aorta. Pulmonary artery to the aorta, so this vessel normally connects the pulmonary artery into the aorta, but during pregnancy, during the gestational period, it can close and remain what they call patent, so it's therefore still evident, right? So it did not fully close. So this can happen with babies that are delivered early, so preterm birth. There's not going to be enough time for everything to heal, to finish developing. Congenital rubella, that's passed on from the mother. Chromosomal abnormalities, we see this a lot with Down syndrome, and then respiratory distress syndrome. So what this one looks like is, again, this is a flow. This is the normal heart, right? So blood, aorta, going out to the aorta, going out to the pulmonary. We've got our chambers. Now, when you take a look over here, it is definitely a different problem here. So patent ductus is right up here. So instead of going through the aorta, we now have it coming in, so it would kind of come in through that pulmonary. So we have a mixture of blood that's happening, a mixture from the aorta, oxygenated blood in the aorta, and then you have the deoxygenated blood in the pulmonary, and that's what causes that mixture. Medicine can happen, and then usually it's going to be an open heart surgery, go in there and try to separate and kind of fix that mixture that's happening between those structures that didn't form. Corrucation of the aorta, this is a narrowing of the aorta in the area of the actual ductus, and that area, the narrowing can be, we call preductal, ductal, or postductal. Either way, it's just a significantly smaller flow, so this aorta is much more narrowed, right? So that's kind of what happens with the narrowing of the aorta, again, in any of those locations, right? So different locations. So what we see with this is hypertension. Obviously, it's narrowed. Blood flow is going to increase, and maternal supplemental oxygen is going to be needed. So, again, you're not getting the blood flow that's going through that aorta. One that you probably have heard of is rheumatic fever or rheumatic heart disease, rheumatic fever that causes rheumatic fever in rheumatic heart disease. And so this is can be picked up. It's not really common anymore. We end up seeing the virus happen when strep throat infections are they're going untreated. And that fever, right, that fever response activates the immune system, and you end up with a buildup of cells and inflammation, and rheumatic fever ends up causing lesions. So those lesions get thick and on the mitral and the aortic valves, and it prevents closure. So rheumatic heart disease stems from a fever that changes the way in which those valves are operating. So what happens with mitral and aortic valve, right, that's where we're getting all that output, cardiac output from, is you have compromised stroke volume and reduced cardiac output. And so for this rheumatic fever with rheumatic heart disease, again, what we're noticing here is blocked, so very narrow, right? So this narrowing of the aorta, I get closer to the computer so you can see what I'm looking at. So narrowing of the valve closure. So thickened lesions on the mitral and the aortic valve, which is what I was showing you here, and that is going to prohibit the blood flow from getting out and into the systemic circulation. So over time, we end up with congestive heart failure. This weakened heart, medicine, diuretics, beta blockers, ACE inhibitors, or go in there with both medicine and repair or replace. They're one of two things that can either replace the entire valve or go in there and repair it. Okay, another one, and we're going to see endocarditis when we look at EKGs directly, but endocarditis, what the endocardium is, right, the layer of the heart, inflammation of the tissue of the heart. So the inner lining of the chambers becomes inflamed. What causes endocarditis? It can be a bacterial or a fungal infection that's ignored, quite frankly. I mean, any age person who's got an inflammation that's going ignored can end up attacking the heart. Strange, but I've seen this happen in young, healthy people or middle-aged people. So it's when this inflammation ends up attacking the endocardium, right, the pillow that supports our heart. It can lead to valve damage, blood clots, lots and lots of problems. So when you're thinking about endocarditis, we will look at it later when we look at some strange EKG things that happen. But it is infected in the areas, the endocardium, again, is like kind of the pillowcase, the sac that covers our heart. As that becomes inflamed, we usually end up also seeing valves that become thickened. And look at how thick this wall is. Right? You don't want the wall thick like that, right? That's definitely not, the inflammation really causes a lot of damage. So with endocarditis, heavy dose of antibiotics, they're usually intravenously, they're hospitalized, really trying to get the infection under control. Oftentimes, a big dose of IV antibiotics can help do that, but otherwise they can go in there and surgically remove some of the inflammation and the debris that's in there by the valve, and or, like I said earlier, go in and replace the whole valve. Okay, one that I know you all know about is heart disease. So again, these are beginnings of getting into EKGs as well. What would cause EKGs to look different? So now when we think about heart disease, we know what it is, right? It's the coronary arteries that become plaque filled, atherosclerosis, inflammation. So accumulation of cholesterol and fat gets clogged in those arteries, and we end up getting less oxygenated blood flow going through the arteries, and we become the word ischemic. Right? Ischemic means less oxygenated blood flow. When someone gets ischemic, they usually become symptomatic. That symptom of ischemia is angina. Right? So if someone is ischemic, they usually produce these angina symptoms, right? Chest pain, shortness of breath. All of this stems from inflammation that's happening inside those coronaries. What leads to inflammation? Risk factors: obesity, diabetes, cholesterol, being sedentary, right? I can go on and on, right? You know what those are. So ischemia, that word ischemia is something we talk about in all of my classes because it is the pretty much the end product of what's happening with heart disease, with CAD, coronary artery disease. Ischemia is triggered by many different risk factors. Some of these risk factors domino the process faster than others. It can be heredity, so there can be some genetic. It's also a little more familiar, which means sometimes we think that we get heart disease because it's in our family line, but could be, right? We could have some genetic predisposition, but a lot of times it's more this familiar, which is how bad habits, right? So what kind of meals you eat, how active your family is. A lot of times you think things are heredity, right? You see this heredity, this common thread through members of a family, but more it's their habits that pick up because we live in homes with each other and we eat the same foods, we are active or inactive, and all of these things. So coronary artery disease, the symptoms, once you become ischemic, angina, nausea, abdominal pain, it feels like indigestion, heartburn, dizziness, sweating, all of these things can be classified. And I know you know the basics of this, right? So this lumen should be nice and free of any fat and plaque. It should be nice and clear so we could get the blood flow can go right through there. But instead we have this inflammation that happens at the endothelial layer, and fat and cells begin to accumulate. Blood can no longer get through, so we're not getting the blood flow we should, and then what we end up seeing is symptomatic heart attack, death, open heart surgery, any of these. So lifestyle modifications is the key, right? That's kind of the fundamental of what you're learning as an exercise physiologist. What are the lifestyle modifications we need to make? Right? So sedentary, reading food labels, activity levels, sleep, what they're drinking, what they're eating, medications, statins, ACE inhibitors, beta blockers, nitroglycerin, calcium channel blockers. Those are like common ones. And then they could go in and do an intervention, revascularization. So they can go in and do a CABG, which is open heart surgery, right? CABG, a CABG open heart surgery. They can do PTCA. PTCA is angioplasty, go in through the arm or through a leg and put a balloon, and that balloon open up that blockage. Or they can do the balloon with a stent that gets in there. If ischemia continues, right, if that blood, that clot, right, so when I showed you this photo of this not getting blood flow through, if this continues over time, I mean, we never know how much time it's going to continue. It can be a couple hours, it can be a couple days, weeks, months, we never know. We can end up with a full-blown heart attack, right? Myocardial infarction, fancy name for heart attack. So what happens when you have a heart attack is cardiac muscle has gone through irreversible death. When someone says they had a heart attack, part of the cells on their heart have died, necrosis, cell death, right? So cell death happened because of hypoxemia. We're not getting blood flow. Other complications of MI, a heart attack can be pericarditis, thrombus, embolism, rupture, heart failure. This is what it looks like. Okay, so this is our heart, right, with all these coronaries, right? And we got some blood that accumulates over time, but these coronaries need to be free of blockages. As time goes on, we start getting blockages, and now you can see we're not getting the blood flow. So this picture down here is showing you what's causing this, right? So nice, clean artery getting the blood flow. Now we're getting a little blockage, and now a little more, and now complete block. So here is we're getting a little bit of blood flows getting through there. So someone is probably ischemic or asymptomatic, they might be ignoring it, who knows. By the time they get to a complete occlusion, no blood flow is being able to get through there. Right now, this whole, wherever the blockage might be in the heart, so if the blockage is up here, this whole area is starved of blood flow. The blood can't get through this clogged artery, and now these cells died. Fancy word for cell death, myocardial infarction. Right? So how severe someone's MI is really means what kind of, how much cardiac muscle died, right? What kind of necrosis happened. So intervention. Within 4 minutes, we can save cardiac tissue. 4 minutes, guys. So when someone starts having angina, get to the hospital. Once that angina goes to full-blown heart attack, it is time. It is a ticking time bomb on, are they going to survive? Are they going to end up having cell death? What's going to happen? So they can do different procedures, like I mentioned, PTCA, which is a balloon and a stent. Right, go in there and inflate the balloon and then deploy the stent. Or they can go in and do CABG, C-A-B-G, coronary artery bypass graft. That's where they saw the sternum, open up, and bypass and put some new bypasses on there. So when someone has these blockages, right, we want to act fast. We want to not ignore symptoms. We want to get them to the hospital. Time is muscle, right? So we want to try to avoid from them getting to the full-blown heart attack. We want to try to save them early, even earlier, by intervention and keeping their risk factors and behavior in good shape. So again, cardiac rehab is the end result is getting into an exercise environment where they're monitored on an EKG, having somebody like yourself monitor behavior modifications, helping with diet, exercise, stress. The full thing is, right, what cardiac rehab is: lifestyle modifications, risk factor management, get them to adhere to a new lifestyle, because now we can lower their risk for having more problems. Heart failure is something we're seeing more and more of. Heart failure is different than heart disease, right? Coronary artery disease, what we just went over, is blockages in those coronary. Heart failure is when the actual wall, the thickness of the heart becomes, contractility and cardiac output becomes diminished. If that makes sense, right? So it's a heart that has been exposed to many years of risk factors: cholesterol, diabetes, obesity, sedentary, all those things. It could be a heart that has survived a heart attack, right? Any of these types of structural problems can be what stems into what's heart failure. With heart failure, people present shortness of breath, fatigue, low energy. They have a lot of swollen neck and fingers and legs, edema overload, dyspnea, hypoxia, skeletal muscle atrophy. Heart failure is commonly what maybe old people in your family, oftentimes the cause of death, where they say that grandma's heart got weak, grandma's heart wasn't pumping correctly. That's what we call heart failure. So this is a nice photo to show you, right? So pathological change in a normal heart versus an enlarged heart, right? So here is our nice muscular wall, right? This is a cross-sectional view of, right, our atriums, our ventricles, and this muscle, right? This muscle, the myocardium, is what contracts and gives us their blood flow. And what we see over here is we see this enlarged ventricle. This ventricle gets widened, and enlarged ventricle is not good. And enlarged aorta, and very inefficient at pumping and getting the blood out. So very ineffective, shortness of breath, overflow of fluid. There's not a lot to do. It's lifestyle, medicine, controlling their hypertension, watching their sodium. Really trying to avoid heart failure is initially changing risk factors. So all of you right now at this age, in your 20s, changing risk factors now, so in 20 years you're not trying to fix these later, is a common one. So those are our giant structural problems. Many of them you may know from other classes: congenital, heart, then we've got coronary heart disease, interventions being a stent or a balloon, or an open heart surgery, and then heart failure. So we will look at especially ischemia. I'm going to talk a lot about ischemia on the EKG, what ischemia looks like on an EKG. As we get into EKGs, we're going to do this, and many weeks from now we'll come back and do this. This week you are reading and you are writing. So this week we are reading a very long article on stress testing. It is broken down into 3 parts. Only part 1 is due to this week. So spend some time stress testing, because as we learn just read EKGs, the end product is, can you run a stress test? And of course, this class is virtual this year, so we're not in the lab learning how to use the machine, but we're going to do the best we can doing things remotely like this, watching videos and learning. So anyways, this week you are reading.